Welcome to our 10th session. Today we are having Dr. Sunitha Daniel taking a session on gastrointestinal symptoms. So we can start with ma'am presentation. We can have it for around 40 to 45 minutes followed by 15 minutes of discussion. Around 4 we can start our case presentation followed by its discussion. So we can wind up our session by 4:30. So thank you all for joining in. Do make it an interactive session. Over to Sunil sir.
Dr. Sunitha is not a new person to all of us, but for the sake of official purpose, I'm once again introducing Sunitha. So she has done her MRCP in palliative medicine from UK, and she has been working in UK as well as in India. And right now she is working as a part-time consultant in palliative medicine at General Hospital Ernakulam, and she has been helping us with conducting many echo sessions. And welcome, Dr. Sunitha, and it's our day.
Sorry. Can you hear me now?
Yeah.
Okay. Thanks for giving me another opportunity to take the class again. So today we are doing two topics. We're doing nausea, vomiting, and constipation. So I'm trying to do it pretty quickly so that we can cover all the topics. So going straight on to what I'm going to cover for the first session is introduction of the topic. How do you assess a patient? What's the pathophysiology behind each causes of nausea, vomiting? What are the receptors involved, because that's important to know about receptors to know about the management, and then a bit of research. Next slide, please. So when we talk about nausea, vomiting, we need to distinguish, or we need to define the three symptoms. So what is nausea, what is vomiting, and what is retching, and what is regurgitation. So nausea, the first one, it's basically the sensation. It's the unpleasant subjective sensation when the patient or the person has a feeling of need to vomit, but might not end up having to vomit. So it's a sensation of unpleasant sensation of feeling to vomit, and usually it is associated with autonomic symptoms, which might or might not get relieved once they do have an episode of vomiting. So they can have pallor, sweating, salivation, and tachycardia. Next slide, please. So what is retching? Retching is a process of, when we, just before we vomit, that rhythmic spasmodic contractions, which is done by both the diaphragm and the abdominal muscles, and which facilitates, so basically when we all know that when we start vomiting, the contents from the stomach has to come to the esophagus and then has to come out into the mouth. So by contracting the diaphragm and the abdominal muscles, it will facilitate the regurgitation of the contents into esophagus and then end up in the act of vomiting. Next slide, please. And vomiting is the expulsion of the gastric contents. And again, it involves a forceful and sustained contraction of the abdominal muscles and the diaphragm. This is a slide which shows how the higher centers are involved in the whole process of the act of vomiting. When we go into receptors, we'll talk in detail of where the receptors where the cause of nausea, vomiting acts on receptors in the brain. So we'll be seeing that session. But here, basically, it starts in the vomiting center. So the vomiting center has already got the trigger to start the act of vomiting, and that will send the nerve signals to cross the act of vomiting. So it goes to the abdomen, increases the abdominal pressure, and it will squeeze the stomach, and then it relaxes the lower esophageal sphincter, whereby the contents from the stomach will come into the esophagus, and then it causes a closure of the glottis, and then it ends up in the cascade of vomiting. And it also involves the contraction of the diaphragm and the abdominal muscles. What's the instance? Why is it important for us to deal with this symptom? So it is also a common symptom. We can see that 20 to 30% of all the patients with advanced cancer can have nausea, vomiting at any point in their cancer diagnosis, and it's a common symptom the last week of life. So 70% of patients in the last week of life suffer from nausea, vomiting. Also, you must have learned about the side effect of morphine. So 30% of patients who are started on morphine during the first week can have nausea. And it's in cancers, which cancers can present with the symptom is advanced gynecological cancers 42%, advanced stomach cancer 36%, and advanced breast cancer 20%. Why is it important? So we know it's common, we need to manage it. Also on top of that, it has got other effects on the patient, because most of the medications that we give for other symptoms we give orally. So once the patient has got nausea, vomiting, you can't absorb the other medications either, so that will lead to a poor control of the other symptoms. They'll also have a reduced oral intake of food and fluid, which will contribute to weight loss and fatigue, which again leads to significant dehydration. It will cause electrolyte imbalance like hypokalemia. And if the patients are already on other medications like ACE inhibitors, NSAIDs, and diuretics, when we have nausea, vomiting, and dehydration, it can precipitate the drug reactions and as well as renal failure secondary to that. This, like any other symptom, will affect the family and the carers. One slide about regurgitation. Regurgitation is not typically, so patient can present, especially typically patients with the obstruction to esophagus can complain that they're having vomiting. But when we go into detail of that complaint, it's mostly regurgitation rather than vomiting. So it's usually secondary to obstruction of esophagus. Because it's important to know the difference between the two, is because sometimes regurgitation, we can do surgical procedures like endoscopic stenting if it's appropriate to to control the symptom. And the disadvantage of the symptom is that sometimes it's not relieved by antiemetics. Even if you give antiemetics, the symptom might not be relieved. Persistent nausea can respond to appropriate medication, but the physical symptom of regurgitation might not be relieved by antiemetics.
Sunitha, there is a lot of background noise. Is it from your end? Can anything be done for that?
I think it's some team meeting going on in the department. I'm not in that room, but I'll try.
Yeah.
I'm not sure I can get in the room. Is it very disturbing?
No, it's okay.
Sometimes it is disturbing, but
Okay. I'll hold the microphone near. Then probably it might be better.
okay.
So I'm really sorry about that. I'm doing it the first time from here. Okay. So can I have the slides bigger? So what's the mechanism involved? What's the neural pathway involved in the yeah, okay, that's fine. So basically, the whole pathophysiology is involving three regions of the brain. We've got the CT instead of the chemoreceptor trigger zone. We've got the vomiting center, and we've got the nerves from the medullary antiemetic tone. Next slide, please. This picture shows where all these regions are situated. We've got the CT instead of the chemoreceptor trigger zone in the base of the brain near the fourth ventricle. And the important thing is it doesn't have any blood-brain barrier. The other nerves involved, like nucleus tractus solitarius, we've got the medulla oblongata, the pons, and the vomiting center is quite nearby. The important thing about the CT is that, as I said, is the blood-brain barrier is not very active, and that's the reason why one of the cause of nausea, vomiting in our population is toxins and drug-induced. So it basically acts on the CT set and the receptors involved there, and hence the medications that we use to manage the vomiting because of toxins also act on the receptors that are in the CT sets. So next slide, please. So CT set located in the area prostomy of the floor of fourth ventricle. There's no blood-brain barrier. The receptors which are present there are dopamine and D2 and 5-HT3. It's important for us to remember all these receptors. Now, the final slide, when we come to the management session, I'll show a slide or a graph where all the receptors are seen together, because it's important for us to know the receptors to decide which medications will act for a specific symptom. Next slide, please. So from CT, the signals goes to the vomiting center, which is located in the medulla. And when I showed you the slide about the neural pathways from CT goes to the nucleus of tractus solitarius and the reticular formation, the medulla oblongata. And that's how the process of the triggers of vomiting starts, and then the physical act of vomiting happens. The receptors involved here are histamine, H1, the acetylcholine, that is ACH, and the 5-HT2 receptors. Third one, the medullary neurons. This is a theory. It's postulated that medullary neurons are also involved in the act of vomiting. It's not been proven, and what that has been hypothesized is the encephalnergic pathway of the medullary neurons are involved in the act of vomiting. Basically, what they do is they will inhibit the antiemetic tone, which potentiates, when the antiemetic tone is inhibited, it will potentiate the effect of CTZ zone. And that is why because encephalnergic pathway is postulated, what we believe is that when we displace the enkephalins from their receptors by naloxone or opioid, will reduce the antiemetic tone, and that is responsible for the vomiting because of naloxone or opioids. And also the chemotherapy causing nausea and vomiting again can be because we inhibit the enkephalin synthesis, and that will displace and that will reduce the antiemetic tone. But this is just a theory that's been postulated. Next slide, please. What are the other receptors which could be involved, or as a causate of nausea, vomiting? So we've also think that the GABA receptors in the cerebral cortex and the 5-HT can be involved, and also the mechanoreceptor receptors in the meninges. So these are involved when the nausea, vomiting because of raised intracranial pressure. When the the receptors in the meninges are stretched, that's because of these. That's a cause for these receptors involved for that cause of nausea. Also, GABA receptors are postulated because in some cases of, you can have something called anticipatory nausea or anxiety associated with nausea, causing nausea and vomiting. And in that's where we give benzodiazepines for nausea vomiting, which acts on the GABA. Next slide, please. Then the vestibular system. So the motion sickness causing nausea and vomiting. So vestibular system is responsible for that. And the receptors involved is acetylcholine and histamine. Next slide. Coming down from the brain down to the gut, how does what receptors are involved in the gut and serosal surface, which we have got 5-HT3, acetylcholine and H1. So these are the direct effect of whatever can be gastric stasis or gastric please.
Dr. Sunitha, can you hear us?
It's not moving.
We can't hear you. We were not able to hear you in between.
Okay.
Okay. So can you repeat it again, ma'am? This slide.
So this slide. So the next receptors are the ones in the gut and the serosal surface in the viscera. We've got 5-HT3, the acetylcholine and H1. These are responsible for basically for the gastric stasis and the direct irritation of the contents in the stomach. So how do you assess a patient who's got nausea vomiting? So when the patient comes to you with a history of nausea vomiting, one, proper history is important. Again, why is it important? So I mentioned about distinguishing between, is it regurgitation, is it nausea, is it vomiting? So we need to take a separate history for both nausea and vomiting. We need to know about the triggers, the volume and the pattern. What are the exacerbating and the relieving factors? Have they tried anything? What are drugs they tried? What are the
Dr. Sunitha?
Yeah. Shall I stop the video then?
Okay, sure, ma'am. Sure. Yes, ma'am, you can continue now.
Okay, can you hear me now?
Yes, we can.
Okay. So when a patient comes to you, with a history of nausea and vomiting, a proper history has to be taken, both for separate for nausea and vomiting, and also to distinguish between whether it's regurgitation. So how do you do that? You have to ask about the triggers, the volume, the pattern, what are the exacerbating and relieving factors, and what are the, including any combination of drugs they have tried and the routes they have tried, about the bowel habits, and are they on any other medications? Is any other new medications have been started? Is that causing the new symptom? Next slide. What do you do for examination? How do you assess a patient? First important thing is look for signs of dehydration, for sepsis or any drug toxicity, any effect affecting on the central nervous system, and examine the abdomen for organomegaly, bowel sounds, and succussion splash. Why do you do the blood investigation? Again, to find the cause of the symptom. So one of them can be uremia, renal failure causing nausea. So you have to do a urea and electrolyte tests. Other one, it can be hypercalcemia. So electrolytes are important. Liver function test, again, end stage, it can be hepatic encephalopathy or liver failure. So LFT is important. Calcium, blood glucose, and a patient can present with an infection, and the presenting complaint can be nausea, vomiting. So dip urine for possible infection. What is the principles of management? We will be discussing both the non-pharmacological as well as the pharmacological measures. First and foremost is when we do all the investigations, when we examine the patient and do the investigations, if you find anything correctable, so if there's uremia, there's hypercalcemia or constipation, try and manage correct the correctable. And then look for non-pharmacological measures to manage the symptom. If you can find the cause of the symptom, an antiemetic that is appropriate to the identified cause, so that will be based on the receptors. Sometimes a combination of antiemetics may be appropriate. And in the third stage, if nothing works, we have to go for a broad spectrum antiemetic, which can be indicated if multiple concurrent factors are present. So a bit slides about non-pharmacological management. Again, correcting the correctable. Pay attention to oral care and hygiene. So we must have seen the patient with recurrent episodes of vomiting. They'll have a coated tongue. They'll have foul smelling mouth. So basically, pay attention to that, and that itself can worsen the symptoms. They can even have oral thrush. So once when we deal with the management, we have to pay attention to the oral care as well as proper hygiene, and also look at the bowel habit and regularize the bowel habit. Advice about the meals. We don't have to, technically, if you don't suspect any bowel obstruction, or we don't have to keep the nil by mouth, or ask them to stop eating or give a rest to the gut. They can be advised to take regular but small palatable portions rather than a large meals. Some people, the smell of food can trigger nausea, so avoid food preparation if near the patient. Avoid the cooking smells. Try and manage the patient in a calm and reassuring environment. Acupuncture seems to have a role in intractable nausea, vomiting. So you must be familiar with the acupuncture techniques. It's like dry needling technique, and they've got different points where different points are used for different symptoms. So usually the wrist near the wrist is the acupuncture point for the this symptom. So there's the things like acupressure bands or C bands are available if you're interested in acupuncture, or acupuncture itself can be done for the symptom. Okay, non-pharmacological management continued. So you have to minimize or discontinue the offending medication. So again, morphine, we might not technically be able to do that. We can't stop the medication, but you can start an antiemetic along with that. If it's any other medications that is known to cause the symptom, then if it's possible to stop that, we can stop that and see. Sometimes distraction, visualization techniques, relaxation techniques might help. Music therapy seems to have a role as a non-pharmacological management. Then, if there's any other symptom that is contributing to nausea and vomiting, so pain, controlling pain, and addressing the other social, psychological, and spiritual issues is also important. Okay, so this is the one slide which is important thing to understand when we go into the details about managing. And this is something, if you're able to keep this in our mind, we might be able to manage all the symptoms. So starting from the top, if you go to the vestibular system, so all the things written in red are the receptors that is present in each area. So as I mentioned when I was talking about vestibular system, the receptors are H1, histamine, and the acetylcholine. So that is the receptors in vestibular system. And what symptom, what is the cause of nausea, vomiting that is involving vestibular system is it can either be motion sickness. So things that are written in blue are the causes. So it can be motion sickness, it can be opioids, or it can be base of skull tumors. They are the reasons which can affect the vestibular system, causing nausea, vomiting. And what is the drug of choice, of which drug acts on the receptors? That's in green, that is cyclizine. Coming to CT, so the chemoreceptor trigger zone. Again, we discuss the receptors. So there's D2, 5-HT3 and NK1 are the receptors. So what are the cause of vomiting, affecting CTSDs? We've got drugs, metabolic, and toxin. All this because there's no blood-brain barrier. So that is a reason for that. And which medicines will act on these receptors? You've got haloperidol, metoclopramide, and aprepitant. Aprepitant is a newer one that has been tried for chemotherapy-induced nausea, vomiting. It's quite expensive. I have one slide at the end about aprepitant, and it acts on NK1 receptors. So NK1 again at CTSD. And then we come to cerebral cortex. I mentioned this earlier on. GABA receptors. So there's mechanoreceptors surrounding the cerebral cortex as well as GABA and H1 receptors. What are the causes that can affect the cerebral cortex? Is either pain, fear, anxiety, or raised ICP. They've only mentioned cyclizine there because H1, but GABA, that's the reason we use benzodiazepine for pain, fear, anxiety, and again to manage nausea, vomiting. And coming down to GI tract, the receptors are 5-HT4, which is a prokinetic action, and D2 receptors, activation of which slows the gastric emptying. What is the cause of this? In GI tract, there are two causes. So one is gastric stasis, and the other one is the visceral or the serosal reason. So gastric stasis, if gastric stasis is a cause of GI tract causing nausea, vomiting, the receptors involved are 5-HT4 and D2. Basically, activation of these receptors can slow the gastric emptying. So what medications are used for that is domperidone and metoclopramide, which are prokinetic, which it acts on these receptors and work as prokinetic. Other one is 5-HT receptors, which acts on the vagal nerve, leading to emesis, and the acetylcholine receptors, which blockade of them leads to slowing of the gastric tract. So the reason could be visceral and serosal reasons, and cyclizine will slow the transit. So this slide shows that both cyclizine and metoclopramide will act at the GI tract, but they're both antagonistic, and that's the reason why both of them are not advised to be given together, because one will antagonize the effect of the other. One is a prokinetic, and the other one will slow the gastric tract. The cyclizine is used for subacute bowel obstruction with colic. If there's no colic, we go for metoclopramide. Finally, all these will come to vomiting center, and vomiting center has also got its own receptors. So we've got H1 there, again acetylcholine is there, 5-HT and NK1 and mu receptors. What are the causes which acts directly on the vomiting center? We've got raised intracranial pressure, just like the cerebral cortex one, and meningeal infiltration. And what are the drugs which can be used? Is cyclizine and levomipramycin, as well as aprepitant, because aprepitant works on the NK1 receptors. Next slide, please. So this is again similar to the previous slide, where I've gone with the different causes of nausea, vomiting, and which drugs will act. So for here, first is the metabolic or biochemical upset. What will be the clinical picture? The clinical picture would be the patient would be having persistent and severe vomiting, and there is little relief from vomiting or retching. They still have continues to have nausea. And what is the site? Whatever is metabolic or biochemical, it is CTSD, because there's no blood-brain barrier. So remember like that, CTSD. And what is the cause of that? The cause is either drugs, or it can be carcinomatosis or chronic inflammation. And what do you give for that? We can give either haloperidol, or you can also give metoclopramide. Haloperidol 1.2, so doses are 1.25 milligram PO and subcut. We can also give metoclopramide 10 milligram 4 times daily, orally, or subcutaneously, and levomipramycin. Second one is motility disorders. So how do you distinguish from motility disorders? The patient presents with intermittent, large volume vomiting, usually relieves symptoms temporarily. So once a patient has a large volume vomiting, the nausea and vomiting get relieved temporarily. They can also have early satiety associated with the symptom. They can have reflux, hiccups, and often little nausea until immediately prior to vomiting. Something like projectile vomiting, where they don't have much of nausea, but only little nausea is there, which usually happens prior to vomiting. So what are the causes of that? Can be either because of gastric stasis, gastric outlet obstruction, or pseudo obstruction as an intestinal. And that's a site. And what can cause a gastric stasis? It can be an autonomic neuropathy by paraneoplastic syndrome. It can be metabolic causes like hypercalcemia, mechanical obstruction, enlarged liver causing a squash stomach. So what works for that is something it's a prokinetic will work for that. So we've got metoclopramide. Again, you can give it per orally. or as a syringe driver, as a continuous subcutaneous infusion. You can also give domperidone. Domperidone, the good thing is it doesn't cross the blood-brain barrier, so it doesn't cause extrapyramidal side effect. But the disadvantage is it only oral preparations are available, so you can't give it by subcut route. Now, erythromycin is also a potent prokinetic agent and sometimes can be used as a 250 milligram QDS doses for a prokinetic effect. If you suspect there's something compressing the stomach or any external tumor, you can give a course of dexamethasone, 4 to 8 milligram. You can reduce the dose after 3 days, or we can also go in the route of stenting. Next slide, please. If it's intracranial disorders causing nausea, vomiting, the patient can present with headache, other clinical features of headache, altered conscious level, vertigo, dizziness associated with nausea, and also motion sickness or movement-related disorders. The site is raised ICP. It can also be in the vestibular nerve or inner area stimulation caused by a space-occupied lesion at the base of skull tumor or toxic. See? Did I break off again?
Yeah, that was for a few seconds.
Okay. Shall I just continue?
Yeah, please move on with the intracranial disorder.
Okay. So the drugs are cyclisine, 25 to 50 milligram, or we can also go for hyoscine hydrobromide. And again, you can also try dexamethasone for that. So dexamethasone basically will reduce the intracranial pressure and reduce inflammation and can act as an antiemetic. If you suspect inner ear, we can also go for cinnarizine. And levomepramycin is a broad spectrum antiemetic which covers all the receptors. So that is something that can be given for that also. And if you come to gastric irritation, like ulcers, patient can present with constant nausea, worse on eating, and they can also have reflex symptoms as well as colic. It's usually because of the stimulation of vagus. It can be tumor, toxins, inflammation, or infection, or a foreign body. Again, we can try hyoscine hydrobromide, either as an orally or a subcut. You can try antifungals, antivirals, antibiotics if infection is suspected. If you suspect ulcers, we can try ranitidine, proton pump inhibitors. Sometimes prokinetic agents can trigger a esophageal spasm. So sometimes if esophageal irritation is there, we might not. It would be better not to give prokinetic agents. Next slide, please. Then final one is when either we do not know the cause of nausea, vomiting, or there's a multifactorial reason, and also the higher centers are involved. So again, the site is unclear. It's postulated that the higher centers, the cerebral cortex, the GABA is affected, but we're not very sure. But we can try levomepramycin, which is a broad spectrum antiemetic that can be tried. We can also try steroids. So usually when we reach this point, the patient would have presented with nausea, vomiting. We would have tried the conventional ones. We would have tried metoclopramide probably. We could have switched to cyclisine. If it's not working, we would have given ondansetron. We would have tried everything. If that's not working, then we might add on steroids. So that's the role of steroids when it's intractable nausea, vomiting. It's not working. You give steroids 8 milligram. Again, reduce after 3 days if it's not working and aim to stop. If you think the highest center origin is there, especially some people with chemotherapy, after once they have a chemotherapy and have had very bad nausea, vomiting, some people can develop the symptom even before the chemo is given. So they know that they're going for chemo next day. They might have the symptom the previous day. So they anticipate the symptom. So there's anxiety involved. You can give lorazepam or diazepam for such patients. Next slide, please. Okay. Just the general points. We've covered the drug now. I told that you can give adjuvant steroid or benzodiazepine. I mentioned this cyclisine and the anti-muscarinic drugs will block the final common pathway through which metoclopramide acts. So this is explained to you in that slide showing the receptors. So they both antagonize each other. So don't give cyclisine and metoclopramide together, or any anti-muscarinic drug and metoclopramide together. In fact, I've seen patients who would start on amitriptyline when they're already on metoclopramide, and their nausea and vomiting got worsened because technically that also can interact together. So because anti-muscarinic effect. if you're giving as a syringe type, if you're mixing together, cyclosporin and buscopan can crystallize. That's why don't give it together. The route of administration, if you're giving it orally, it might not provide the adequate absorption. It's always better to give it at the buccal or sublingual medication or a parenteral route. This is just about all the medications that I've covered. It's just for your learning purpose. So metoclopramide, we know it's D2 receptor. It can act on 5-HT3 in higher doses. It's a prokinetic agent. What's the dose? You can start 10 milligram 3 times a day. Sometimes we give up to in a PCF it says 90 milligram. I haven't given up more than 90 in my clinical practice. It doesn't work. You can give it PO, IV, and subcut. Its indications are gastric stasis, opioid-induced, and chemotherapy. The thing to worry about or look out for is extrapyramidal symptoms, especially when we give higher doses at longer time, longer duration, then always look for extrapyramidal symptoms. Next slide. Haloperidol, again, very good antiemetic, works in D2, causes opioid-induced and metabolic. Doses is 1.5 milligram to 3 milligram TDS. You can give it PO, subcut, or IV. Max is 20 milligram. For nausea, vomiting, I haven't given that higher doses, but it's suggested you can give it. This can also cause extrapyramidal symptoms, so we have to be very careful and don't ideally avoid giving haloperidol and metoclopramide together because it can worsen it. Next slide. Hyoscine or buscopan, anticholinergic. So hyoscine butyl bromide is buscopan, acetylcholine receptors. So this is again antagonist to metoclopramide. So it acts in the opposite one. It is for intestinal obstruction with colic to slow the gut down. We can give this. Again, you can give a subcut or IV. Maximum, usually I go up to it 4 times a day or 160 milligram to 180 milligram. It can also be given peritoneal meds, and it can cause dry mouth, tachycardia, and blurred vision. Next slide, please. Cyclosporin, again, H1 and acetylcholine receptors. It's indicated for vesicular causes and raised intestinal pressure and intestinal obstruction. Dose can be 25 to 50 milligram TDS. PO and subcut can cause sedation and dry mouth. Next slide.
Dr. Sunitha? I hope there is some problem with Dr. Sunitha's connectivity. We will wait for a second. She will be relogging in. Dr. Sunitha? Yes. Yes,
Hello?
Doctor, I can hear you.
Okay. Next slide, please. Dexamethasone, how does it work in nauseas? It reduces the intracranial pressure and reduces the peritumor edema. It will also reduce the permeability of blood-brain barrier to the chemicals. Usually, we have to give higher doses, 16 milligram for 3 days, and subsequently can be reduced to 4 to 6 milligram daily. Next slide, please. Benzos for anticipated nausea and vomiting. You can give GABA antagonistic, lorazepam 1 to milligram HS. Next slide, please. Levomepramycin is a broad spectrum antiemetic. Again, covers all the receptors, and normal dose is 60 to 12.5 milligram per PO subcut. Stat can also be given QID. Next slide. One slide about the NK1 receptors. So this is something that's relatively new in chemotherapy world. They've given as an adjuvant treatment to prevent nausea and vomiting with moderately and highly emetogenic chemotherapy. Initial dose is 125 milligram and dose to be taken 1 hour before chemotherapy, and 80 milligram once daily for 2 days. The other preparations available are fosaprepitant, rolapitant, and nutupitant, but only aprepitant is available in India, I think. Next slide. Ondansetron is, we are very familiar with ondansetron. The other preparation similar to ondansetron is granisetron, which comes as a patches, adult, the patch is 3.5 milligram in 24 hours, 7-day patch. It also comes as a oral IV and subcut preparation. And another one is palonostrone. And this is octreotide has a role in bowel obstruction. Typically, octreotide was used for carcinoid tumors with features of carcinoid syndrome, VIPomas and gluconomas. How it works, it reduces intestinal secretions in palliative care and reduces vomiting due to bowel obstruction in palliative care. It has to be given as a continuous subcutaneous infusion. And for intractable vomiting, secondary to bowel obstruction, octreotide has a role. The doses that we start is 0.25 to 0.5 milligram over 24 hours, and maximum is 0.7 milligram over 24 hours. Just a bit about the research. So this was one of the actually maybe the only research that was done among the antiemetics. So it was randomized open-label study of guideline-driven antiemetic therapy versus a single-agent antiemetic therapy in patients with advanced cancer and nausea that's not related to anti-cancer treatment. Next slide, please. What they tried to do was it's a randomized trial, and in one arm, what they did was all the patients were given antiemetic depending on their causes. So it's a guideline driven, just like what we have studied. One arm only received antiemetic in accordance with the cause-based guideline, and the other arm just received single agent haloperidol. So what they found that there's a greater response rate was seen in the guideline arm than the single agent arm at 24 hours. So basically it means that when we start treatment, depending on the cause, if we say suppose a patient has got gastric stasis and you give metoclopramide, first 24 hours they've got better response, but after 48 hours or 72 hours, both the arms, those who got just haloperidol for nausea vomiting due to any cause, and those who got nausea vomiting specifically with etiology based didn't have any benefit after 72 hours. So basically they responded better earlier on, rapid benefit, but after 72 hours both are same. Next slide. I mentioned this already. We can skip this. Next slide. So again, practical consideration, look for hydration, nutritional status. It can be refractory to treatment. Benzodiazepine if it's refractory. Next slide. Always think about interventional radiological stenting, and a passage of NG2 followed by placement of a venting gastrotomy can be preferable to persistent vomiting if there's upper bowel obstruction. So always think about an intervention if it's appropriate for the patient. Next slide. Talk about relaxation, fresh air, and continue to take pain medication as severe pain can make the nausea worse. Next slide. Oral hygiene, oral touch, I've covered all this. Next slide. So just to conclude, it's a common symptom. Proper history and evaluation is important, and treatment ideally targeted to the causes needed. Next slide. Do we have time to go with constipation also today?
So how long would you take, Sandra?
If I just have to cover just the medication, then I'll skip the pathophysiology and do it like that, or it's up to you.
Yeah, I think we don't have any other session on constipation, so I think it would be better to move.
Okay then, yeah. Okay. Just skip that. So how would we decide? The first slide, you can just read it and see this about the research definition of constipation. Next slide. But as far as we are concerned, constipation is too hard stool, too small, too infrequent, or decrease in normal frequency. I'm sure you must be familiar with the Bristol stool chart. So type 1 probably indicates the constipation, and type 7 is a diarrhea, where there's completely watery stool. Next slide. It's again common, 10% population. It's common in general population. The important thing to remember is physical illness is a risk factor for constipation. So they've shown that in a study that comparing the people living in the elderly people living in hospital, 63% of elderly people in hospital were found to be constipated as compared to 22% of the same age group living at home. So once you become ill and reach a hospital, you tend to become more constipated. Next slide. Normal intestinal physiology, we all know how the gut works, and the liquid is absorbed from the large intestine. Most of the time is spent in the colon, 24 to 48 hours. So once the peristalsis is slowed down, that can result in the constipation to happen. And the neurotransmitters involved are, one is acetylcholine and VIP. Next slide. So it's like a vicious cycle. Once a patient becomes constipated, the hardened feces accumulate in the bowel. Diameter of the bowel is reduced. When the diameter is reduced, the time taken to pass the feces is increased, and basically the efficiency of the bowel is reduced, and that will lead to constipation, which goes as a cycle. Next slide. Symptoms: patient can present with flatulence, bloating, abdominal pain, and feeling of incomplete evacuation. That is symptoms of constipation. If they go on to become complicated, they can have anorexia, they can have overflow diarrhea. In elderly, they can also be confused and delirious, can cause nausea, vomiting, urinary dysfunction, and the hemorrhoids and anal fissure can get worse. What are the causes? It can be caused by cancer. The cancer itself can cause because of hypercalcemia or hypokalemia. Any pelvic disease can cause it. Can be because neural plexus invasion. Spinal cord compression is a complication of cancer, can present with constipation, cauda equina syndrome, and patient can be depressed. If it's with debility because of weakness, either they're inactive or in bed rest, poor nutrition, poor fluid intake, confusion, inability to reach the toilet. What are the drugs causing constipation? So opioids are the first in the list. Antiemetics, ondansetron, anticholinergics, antispasmodics, antidepressants. Some antacids can also cause NSAIDs, diuretics, and iron. Opioid-induced constipation is the commonest cause of constipation in our patients. So that is why we are so much worried about this symptom. It's worse in immobile patients, and it's because of the opioid directly act on the gut receptors, and it reduces the forward peristalsis. So it's invariably present in all the patients who are on opioids. It also, there will be reduced sensitivity to rectal distension. There will be a slow passage of feces. Next slide. How do you assess a patient with a constipation? Always ask about the normal bowel pattern. So all the patients may not be having a normal going to toilet everyday bowel pattern. So it's a change in their normal pattern. Look for the frequency, the consistency. Ask for the current and previous laxatives they have tried. Look for the clinical features, whether anything to worry about, is there any complications are there, and look for the possible causes of constipation. Next slide. Examination, look for any masses. You can sometimes feel the fecal mass. Tumor mass also can be fixed, but that is usually hard and not indentable. If it's a palpable fecal mass, it will be indentable with mobile, and it's rarely tender. Next slide. Always do a rectal examination if a patient comes with constipation. One is to look for the hard stools, look for tumor masses, hemorrhoids, anal fissure, or perianal ulceration. Next slide. And the important thing about rectal examination is constipation can herald a spinal cord compression. So you have to look for rectal examination if you suspect neurological deficit, to look for sphincter tone and rectal sensation. Plain X-ray abdomen is a simplest investigation that we can use. We can look, and you can look for, you can actually see the constipated bowel as clumps or rounded masses with entrapped gas and varying degrees of dilated bowel. If it's a bowel obstruction, you can definitely see an air fluid level in that. But here, this doesn't have that. Next slide. Prevention is better. Always tell the patient they can get constipated if you put them on opioid. Increase, ask them to take adequate fluid intake. Fiber is also good. Look for constipating medications. Always give laxatives with opioids and laxative combinations. So laxatives. So the thing to remember is the two types. One is stimulant laxatives. So we've got stimulant laxatives, bisacodyl and senna. All the others comes as stool softeners. So it can be either bulk forming one, which is Asafoetida, methylcellulose. Important thing to remember is you can only give bulk forming if you are able to give a good volume of fluid with that. Then lubricants, liquid paraffin, mineral oil, osmotic laxatives, lactulose, magnesium, and surface wetting agents are docosahexaene, paloxamar. Next slide. So the basic principles of management is, if the patient is constipated, the option is you have to first start with a stimulant laxative. If they don't have any colic, always start with a stimulant laxative. So you can give senna tablets or bisacodyl tablets. If it's not getting any better, you can add a softener to that. So that means if stools become hard, add in a softening agent like a docosahexaene can be added. If the significant colic occurs, then stimulant should be discontinued and a softener should be used instead. That is the first option. Then option B, you can give osmotic laxative, lactulose, magnesium, and milk of magnesia. In patients with liver problems, we always prefer to give lactulose to prevent hepatic encephalopathy. Now, if options A and B has been unsuccessful, then usually progress to option C, that is rectal treatment. So, which includes the suppositories, the enema, manual rectal evacuation. You can give retention enemas, saline lavage, and high-up enema with a suction catheter. Next slide. If it's an impacted soft faces, you can just sometimes give a parectal stimulant laxatives as a suppository. And it's important that the suppository is kept in contact with the rectal mucosa for it to work efficiently. Next slide. Points to remember, it can present with atypical symptoms like nausea and abdominal distension. It can also present with diarrhea, which we have all heard of, the overflow diarrhea. So always exclude constipation if the patient comes with diarrhea. Titrate the dose according to response. Among opioids, methadone and fentanyl are less constipating compared to morphine. So once we switch from morphine to methadone or fentanyl, we have to reduce the dose of laxatives. Osmotic laxatives can cause, long-term can cause electrolyte imbalance and rescue enema suppositories in constipation more than 3 days. Next slide. General advice, encourage good oral intake of 2 liters per day if able, and ensure the patient has privacy and access to health toilet facilities. That is very important as far as especially elderly are concerned. Coming to hospital, that might be the reason they're constipated, because they don't like the toilet or they don't want to, they don't have much privacy. Encourage daily exercises according to ability. Look for reversible causes and titrate the laxative dose according to the response. Next slide. Okay, just one slide of paraplegic patients or bedbound patient. When we want to control the bowel, sometimes if you just give laxatives, they can have spurious diarrhea, ongoing diarrhea, not able, and you can have bed sores and all. So sometimes we might have to do like a bowel regime for them. So you just give them rectal intervention every 1 to 3 days to avoid the possible impaction. Rather than giving them laxatives every day, just give them suppositories 1 to 3 days, and that will prevent them having incontinence, so anal fissures or both. Some people can have like multiple sclerosis can have diarrhea and constipation alternately. So sometimes when they're in a diarrhea state, you have to give them loperamide, and then you can give them suppositories to clear the bowel. Next slide. One word of opioid induced constipation, just 2 slides. How do you manage that? Use peripheral opioid antagonistic to relieve the constipation, but that doesn't affect the pain. So we've got methyl naltrexone and naloxone, which are licensed for opioid induced constipation only under specialist advice. It's contraindicated in patients with GI obstruction or at risk of GI perforation. Next slide. It just shows a dosage. It's only indicated for patients to opioid-induced constipation patients with advanced illness, and they must have been tried on other laxatives and not working. And you can give a subcutaneous injection according to the age of patient. Naloxone is an antagonist of peripheral opioid receptors. It's prescribed orally. Again, similar situation, constipation that is not responding to laxative therapy. Give us a 25 milligram tablet in the morning and reduce 12.5 daily. Not recommended in severe hepatic impairment. When we start naloxone, we have to stop all the other laxative therapy until the clinical effect of naloxone is determined. Next slide. Okay, I think we've covered all that. Yeah, next slide. Yeah, that's it. Thank you. I'm really sorry, it was very quick. I think nausea vomiting should be done so like a discussion one, asking them questions about receptors ideally. So if you got any doubt, you can ask now.
Anybody has any doubts? There should be some.
There should be some, yeah.
Yeah.
Okay, so shall I ask you? Then they need to answer that. If they don't have any doubts, they have to answer the question.
Yeah, I think
So,
that would be better.
Yeah, that'll be better, isn't it? So, what is the first line antiemetic you give for renal failure, nausea and vomiting second to renal failure? Anybody can either type in or write.
Anybody can answer. Please unmute yourself and answer, please. Drug of choice for uremia-induced nausea and vomiting. We can't hear you, Praveen.
No, I'm not answering.
Yeah, you were not answering.
You want to put that slide back at Rajalashmi, that slide with that,
Dr. Rahul has written on dansetron.
no, we'll put that slide back with that colors on, that the brain and all the receptor color, and then try to answer. Yeah, that one. Okay, so now look at the chart and tell me which is the so I said so it's a metabolic cause, right? So it's a metabolic cause. So where is metabolic cause? Which is the drug of choice? Who's going to answer?
This center is stimulated by metabolic problems. Metoclopramide.
Metoclopramide can be given second line, but both written on the first on the top.
Which is the strongest T2 blocker? It is written in the top, and the chemoreceptor triggers on near to that. It's haloperidol.
So haloperidol is a drug of choice when we go for metabolic causes. What's the drug of choice for chemotherapy-induced nausea, vomiting?
Yeah, chemotherapy-induced acute nausea and vomiting. Which center is stimulated?
That's not in the slide actually, but that is something that is a probably pre-palliative question, right? They should be able to answer that. On dansetron. Thank you. Somebody has written on dansetron.
Yeah.
Dr. Shahana sir.
Yeah.
Thank you.
Shana.
So if it's motion sickness, what will you give? So which receptors?
Grace has written Buscopan.
Buscopan. Cyclosine, yeah.
Yeah.
Hydrogen hydrobomide can be given. Hydrobomide is not Buscopan.
But Sunitha, we don't have.
We don't have,
we have only butyl bromide.
Yeah. And cyclosine also, I think some centers in India has cyclosine, right?
Cyclosine is available if you look at the internet, but not available locally.
Locally, okay.
It's available.
Cinnarizine then.
Any of you know about cyclosine? Is it available?
Hyderabad, I think it's available. When I took the class last week, they were telling it's available in cyclosine.
Any of you are using cyclosine? Nobody?
Yeah, people are answering cyclosine. Okay, and what do you give if the patients got anticipatory nausea, vomiting? So they're worried about chemotherapy next day and they're going to have nausea, vomiting. What do you give? Anybody? Raspa. Thank you. Fine. No more questions. Over to you.
Rahul has also written about avomine. Avomine is promethazine.
Promethazine. Okay.
That was for motion sickness.
Motion sickness. Okay. Fine.
Which blocks H1 receptors.
Yeah. Okay. Yeah, that's correct. Any doubts? I think you'll all get the slides. So probably it's clear in the slides. It shouldn't be covered in one hour. But I had lots in the slides. That's why I went very quickly. But go through the slides. If any doubt, just get back to us.
Okay, anybody has any more doubts or comments?
Palanostorm is good for it's one of this. It's like ondansetron, right? So that is, it can be given. But is palanoston available? It's in the slide, but I don't know whether it's available in India.
I think it is available, but it is costly.
It's very expensive, yeah. So if you got ondansetron, then we wouldn't go for palanoston if ondansetron is there.
Dr. Madhulika, are you there?
Hello.
Yeah, is palanosotron available?
Yes, palnositron is not very costly compared to ondansetron because usually ondansetron we give a bolus dose of 16 mg. So the same palnositron we give 0.25 mg. So not much of a price difference between ondansetron and palnositron. So
Okay.
we prefer giving palnositron before chemotherapy.
So what is the duration of action of palanosotron?
Usually a single day dosage is given or unless like ondansetron which is given as TDS. We prefer
Yeah.
giving bolus dose for chemotherapy induced nausea and vomiting. So we don't divide the doses. It's given as a single day dosage per day, one dosage 0.25 mg. And patients are, if they are affordable, we give NK1 inhibitors,
Aprepitant.
aprepitant or fosaprepitant. Yes.
Okay.
So oral tablets are given as 25 mg day 1 and 80 mg on day 2 and day 3. Fosaprepitant is given as a single dosage before starting chemotherapy, half an hour before it. Hello?
Yeah.
Anybody else? Dr. Madhulika, even though we talk about chemotherapy-induced nausea and vomiting, it is not very simple that chemotherapy-induced nausea and vomiting, there are many types of chemotherapy-induced nausea and vomiting, like acute chemotherapy-induced nausea and vomiting, delayed nausea and vomiting, breakthrough nausea and vomiting, anticipatory, and refractory. So,
Yes.
can you just tell us what are the drug of choices for each of the situation which
Okay.
you use in your clinical practice?
So usually for anticipatory, most of the patients when they come for second cycle or third cycle, or when we have already told them that chemotherapy will cause nausea and vomiting, so this anticipatory thing is little difficult to manage. So we usually give them the previous day night we give them lorazepam tablets. So for anticipatory nausea and vomiting, this holds better. So one day prior to chemotherapy, when they are admitted, we give them this. And next day before starting chemotherapy, we usually start them with a bolus dose of ondansetron or palnositron, followed by dexamethasone. So we start initially with dexamethasone. So we continue it for 1 or 2 days, and we stop on the third day. So for acute thing, we usually give ondansetron or dexamethasone. And for late vomiting, it is usually the steroids which take over because many studies they have not proven why steroids play a major role, but steroids have shown to potentiate the antiemetic effects of the other drugs. So we usually add up on steroids along with the other drugs which are used for this. And next thing is um, the late vomiting which occurs after 7 or 8 days, we usually get away with again ondansetron or metoclopramide or perinom, whatever it is. Breakthrough vomiting is very difficult. So when we anticipate this, when we see some patients are actually getting this breakthrough vomiting or they had severe nausea vomiting which necessitated admission for them, we usually give prophylaxis. So here where the NK1 receptor antagonist actually plays. So if they're really very affordable, because the NK1 receptors they cost around 2,400 to 3,000 rupees. So if they are affordable, we prior to chemotherapy itself we start them on this NK1 receptors, and also we titrate the dose depending on the what type of chemotherapy used. So drugs which are causing highly emesis, moderate
Yeah.
emesis, and low emesis. So cisplatin and all is highly emetic. So these drugs usually we give them the routine pre-medications before we start them on anything. But all these medications can cause little cardiac complications. We have to keep that in mind also.
Okay. So So acute chemotherapy-induced nausea and vomiting, which usually occurs within 24 hours after chemotherapy, and
Definitely, yes.
yeah, and delayed nausea and vomiting is after 24 hours up to 120 hours. That's what literature describes. Then breakthrough vomiting occurs in between. So the choice of medications also varies as per the pathogenesis of each of this type of nausea and vomiting.
And
And yeah.
sometimes we also have something called intractable vomiting, where it will usually do not stop, where in that cases we give IV lorazepam. So we try to give IV doses of lorazepam and try to prevent it. So even we see patients, especially females, very young females, breast patients, where they get cyclophosphamide and paclitaxel combinations, they are more prone for this intractable vomiting. So we usually give them IV lorazepam for breaking the cycle.
Uh, so we have to select medication as per uh, the receptors on which the pathology is acts means which receptor is stimulated. You have to block that receptor to have good control of nausea and vomiting. Dr. Grace has some chat question. In my center, anticipatory antiemetic is not usually given before chemotherapy, but patients are managed symptomatically when the vomiting starts. What is your opinion on this? Um, so anticipatory nausea and vomiting is something which has been described well in literature. So even though the mechanism is not very clear, the literature advice regarding use of benzodiazepines. So it is a very defined entity. So I think we have to use benzodiazepines in such situations. And there are some broad spectrum antiemetics also, which acts on multiple receptors. Uh, so in India, the one with broad spectrum antiemetic action is olanzapine, which acts on multiple receptors. But in abroad, methotrexate is available, which they use commonly. But for our purpose, if we use many antiemetics and there is no control of nausea and vomiting, maybe a trial of olanzapine would be good. So, Sunitha, shall we move on to the patient story now?
Yeah, yes, that's fine. Do they have any doubt on the constipation session? That was also very, very quick.
Yeah. Anybody want to ask anything on constipation?
Did they get the was that high suction high enema? Is it clear to everyone? That's something that is we do in palliative care, where if the constipation of the is quite high up, we give this enema, conventional enema via suction catheter. The palliative nurses are quite experienced in doing that. So that's what is meant by high enema with suction catheter. Is any experience with any of them in doing that, or have they heard about that before?
Any of you use higher enema? No, I don't think anybody.
Okay, fine. Yeah. So any questions on both the topic, please email us later on when you read the slides if it's not clear. Okay, we can move on. Thanks, Dr. Sunil.
Dr. Srinidhi?
Hello.
Yes, doctor, we can hear you. You can continue.
Hello.
Hello, doctor, we can hear you.
Good afternoon. Good afternoon, Dr. Srinitha, resident from. Hello.
Yes, doctor. We can hear you. You can continue.
It's audible.
Yes, yes, it is.
58 years old female. 58 years old female. Uh, with a diagnosis of stage 4 CA breast with choroid plexus involvement. Patient is a known case of CA breast. It was diagnosed outside. He with a presenting complaint of blurred vision with difficult pain, back pain, and with headache, vomiting, and tiredness. Initially, the patient had complaints of weight loss for about 6 kgs over 3 months, and right side breast pain for about 3 months, and decreased sleep, loss of appetite, and loss of diminished vision. Patient has diagnosed with CA breast in private hospital outside. She was defaulted because of family problem. She went for Ayurvedic treatment. She developed the symptoms like blurred vision and severe pain. She presented in our OPD with severe pain and blurred vision. Next slide, please.
Doctor, can you see that? We have changed the slide.
Yes. Okay. Can you change over previous slide, please? On examination, patient was conscious. All the vitals are normal. Performance stage is 3. Higher functions are normal. Sensory function is normal. The treatment and significant investigation was clinically we thought as a brain secretaries with increased intracranial tension with suspected. We started with IV mannitol and injection dexa and IV fluids, and routine investigation sent off with CBC and LFT, RFT and serum electrolytes. Now the patient prognosis and outlook was been discussed with his patient's daughter and son for planned for palliative and best supportive care. The family once explained about his life expectancy and willing for the further treatment and the hospital care. The patient was started on palliative chemotherapy and laser treatment to improve her vision. Psychological aspect is his family is nuclear family. Only her son is the breadwinner of the family. Both the son and daughter are not married. In that, her daughter have a bipolar disorder. Nobody should take care of her daughter. Her son stopped going for a job to take her because he needs to take care of her. Worried about his prognosis and lifespan. She was worried about her daughters. The main concern is the worried about the prognosis and outcome of the disease. Nobody to support the family. Worried about her daughter and the son. Deficiency for her self care. Summary of cases. We have 58 years old lady with a stage 4 CA breast with choroid met disease with expected median survival for about 1.5 years, that is 12 to 24 months. Mainly the discussion points is the patient main problem is he lost her vision. That could have been done for this. What could have been done for this? Now with the progress of this is what can be done to improve her quality of his patient life. How can we support her family? Sorry.
Thank you, Dr. Srinidhi. So we have a 58-year-old woman who has stage 4 carcinoma of the breast with brain mets. And her main problems are loss of vision and also pain. Dr. Srinidhi, is it headache?
She has a mild headache, but she now improved with that, all the problems. Only her problem is there is the vision. She improved from all the side effects after the palliative chemotherapy. Now she has presently one problem is she can't see. There is a loss of vision.
Okay. So, anybody has any opinion what could be done, or is it possible to do anything for the vision?
What happened after the laser procedure? It says she got the laser, right? Did it improve?
Yes. No, she has not yet improved. The 3 sections went on with with the help of our oncology of the department.
Okay.
There is no improvement in her vision.
Okay. So what's the cause? They're thinking it's because the brain mets that is causing the loss of vision then.
Yes, there is a meds and increase choroidal meds is there.
Okay. Fine.
Dr. Madhulika, can anything be done for this patient for improving the vision, do you think?
Hello.
It's not.
Hello.
Yes, ma'am.
Dr. Madhulika.
Yeah, this is my patient, and Dr. Srinidhi is my junior resident here.
Okay.
Okay, she had actually come. She's a known case of CA breast treated somewhere with only MRM, and she defaulted for adjuvant therapy, and she presented to us only with vision loss. So by the time she came to the hospital, her vision was totally lost, and she was referred from an eye center, but saying that she's got some deposits in the choroid. So we did following which we did an imaging and found out that there are no metastases elsewhere, but only in the choroidal area. And she came with her daughter and son, and we did because she had some eye symptoms like the watering, irritation, and so many things. So she has undergone laser, but there is no such improvement in her vision, because the ophthalmologists have already said that the vision is guarded, the prognosis is very guarded with the choroidal secondaries. So only her pressure symptoms have been controlled by laser, but no improvement in vision. And she's doing fairly well with her chemotherapy. We have put her on single agent docetaxel. She is fairly well, and no other complaints except for her vision problem. But she doesn't have anybody to take care at home, because her son is left without a job, and her daughter is a psychiatry patient and who's at home now for taking care. So not much of a medical problem to be tackled, but psychosocial aspects needs to be seen, and she is treated by me at present.
Yeah. So, for the improvement of vision, most probably we will not be able to do anything, and most probably we have done all the things what are possible. So from the other aspects, as you told, it is mainly the vision problem and problem with the psychosocial aspects. So what can be done for the psychosocial aspect to improve the quality of life of this patient? Anybody has any solution for the psychosocial problems? They have a nuclear family, and is her husband alive? Or, we haven't had anything about her husband.
He expired.
Okay. So Dr. Praveen says involve NGO to help with AIDS. Is he right?
What about involving the ophthalm team and see whether there's any rehabilitation? Hello, can you hear me?
Yeah.
We are doing it.
Yeah. So like how does she live with the blindness thing? So can you do aids like that, things to help her to live with the blindness? She doesn't have much prognosis left, but can she learn something new and see whether she can manage like that?
Yes, we have, now she completed 6 cycles of chemotherapy. Every visit he's getting an ophthalmology opinion. In ophthalmology department, they are guiding the patient how to do her activities and all.
Okay. Okay.
So here, the most important problem is the psychosocial problems, and I think Dr. Geda has written about the community volunteers. So I don't know whether community involvement and volunteers involvement is possible in your situation, but it is a very good resource that we have to explore more. As medical professionals, we usually don't mingle with other people like who are not medical people, but if we can use this big resource, then most of the problem of this patient can be solved. Even the community can find out a job for the son, or they can take care of the patient and the daughter. Here, especially the daughter is having bipolar disorder, and she needs proper treatment. So the involvement of community in this situation is very important. Dr. Srinidhi, is community support available to you? Are there any volunteers?
Yes, we having a Coimbatore Cancer Foundation in our institute. Hello.
Yeah.
We have a community support like Coimbatore Cancer Foundation. We have a counselor from that institute.
Okay. So, will you be able to arrange some help with the Coimbatore Cancer Foundation for this family?
We are planning to do to the patient. We are already spoken to some people in Coimbatore Cancer Foundation.
Okay. So, is home care available with your institution?
Home care. Based on patient needs, we will make an arrangement to the patients.
Okay. So, Dr. Grace has written about home-based care, so her son can go back to work. Yeah. Patients succumbing to infections are common while on chemotherapy. Yes, that's also true. So, what are the other methods by which we can support this family? Is there anything else that we can do for this family? Sunitha, would you like to add anything else to this? Okay. So, is there anybody who is working in the community in this? Dr. Shanas, do you have any opinion on this? How do you manage this situation if it were in your country?
We have a hospice care here.
Yes, please go on.
We have a hospice care here who go to home for this situation.
They have a hospice care unit who can manage the situation if the patient is sent home.
Yes.
Yeah. Okay. Do you have any opinion on this?
Hello.
Dr. Praveen? Yeah.
Yeah. In my state, they'll be giving pension for the physically handicapped people, like 5,000 per month. Uh, is it available in the state which they are? Because she is already blind, she can produce a handicap certificate that she's a blind,
Yeah.
so she can get a pension from the government.
Yeah, that's a very good point because there are certain types of pension schemes available for patients who are having cancer and also, as you told, handicapped people can get pension. So, Dr. Srinadi, that is one area that you can explore.
Hello.
Have you heard about Dr. Praveen?
Yes, we handicapped a pension scheme is in available in our government.
Okay, so maybe you can give the information to them so that they can get some money. It may not be a huge amount, but still
Uh,
they will be able to have something.
yes, we'll proceed of that.
So,
Yes, Dr. Praveen.
hello.
Yes, doctor.
Yes,
Because
Praveen.
I also thought that her sister also suffering from bipolar disorder. Maybe she will be fit in some psychological patient category in the same way. She can also get some income. So son can go for work and little we can get a financial aid from the government sector.
Okay, yeah. So it is important to know about what are the pension schemes available for and every types of patients that whom we treat. So in this patient, you have done all the possible things for improving our vision, and often
Mm.
people are helping them with helping her with what can be done in the future also. So without having vision, how can she manage in the future? Is something which we need to look for. And psychosocial problems which requires involvement of community and interested volunteers will be a good resource to solve the problem, most of the problems in the psychosocial aspect of this patient. And it is also important to know about the various pension schemes available for types of patients whom we treat. So in this patient, all these things are applicable. So is there anything anybody want to contribute or have opinion? Anything more? If there is nothing, I think we can end the session now.
So I have shared the feedback link. You can take a couple of minutes and do it now itself. So we can continue the session next week on a topic on gastrointestinal symptoms itself, continuation of it, taken by Dr. Sridevi. So you can do the feedback and then leave the meeting. Thank you all for joining.
Thank you.
So thank you all for joining in. So see you on next Thursday. Bye.